approach in day-to-day life, how our juniors inform to us and how we perceive on other side of phone about a case. Like our junior doctors are the first contact person of a patient, and they inform to us in a day-to-day life. We not expect history from a medicine graduate from them, like a detailed history, but they just inform us to like this patient came, and these are the vitals, and now what we can do or what we should do. So we will progress the case as like a real case scenario or what happens in a real life, like what a patient comes to us in emergency and what our junior doctors informs to us, and then we see the patient and what we inform to the referring doctor or physician, and then what we can do in a further scenario. So it was around 11 p.m. at night, and I got a call from a hospital, Manjalpur, that we have a 31-year-old male presented to our hospital with complaint of multiple episodes of vomiting since last 2 to 3 hours, which was black in color, no blood in vomitus. Then there is a multiple episode of loose stools which was watery since 2 to 3 hours. There was no blood or passing stool. Which history given by his wife, she told that she has a severe generalized abdominal pain. Patient went to the bathroom before 30 minutes and had a fall at a home after coming from bathroom and become unconscious since then, and related with him to the nearby hospital. Nearby hospital evaluated him, took a ECG, and immediately shifted to a hospital, explaining that this patient might have some cardiac arrest. So this was the scenario that was informed to me from a phone કે મયુરભાઈ એક પેશન્ટ આવ્યું છે, સિવિયર ઝાડા વોમિટિંગનો કેસ છે અને અનકોન્શિયસ છે અને બહારથી કાર્ડિયાક ઇવેન્ટ છે એવું કહીને આપણી પાસે પૂછ્યું છે અને આપણે આઈસીયુમાં લીધું છે. સો પછી they have informed me to vitals that on arrival to our hospital, patient was unconscious, patient was not responding to deep pain stimuli, breathing was gasping or agonal, carotid pulse were irregular, feeble, with heart rate ranging from 20 to 50 beats per minute, blood pressure was not recordable, he had a bilateral equal 3 mm semi-direct refill which was reacting to light, bilateral distended neck veins, extremely cold peripheries, slow capillary refill time. This was added afterwards when I saw the patient, but it was extremely cold peripheries, slow capillary refill time, cyanosis signs were present. There is no signs of injury or no any bleeding from any side. So in a primary survey, we usually see all the life-threatening injuries first. So what we try to approach in a patient in an airway breathing and circulation way. So definitely this patient having a compromised airway, compromised breathing, and even compromised circulation also. So this patient requires aggressive resuscitation. And good part of our team or every team is that our each and every registrar or doctors are immediately ready to start BiPAP to each and every patient who is comes with breathlessness, and they are also ready to take ABG as soon as possible. Or whatever with the first investigation we want to take. If you ask a junior doctor, they will ask them, if patient is very sick, I will try to take ABG as soon as possible. So, and that is the very fast report that usually comes to us, and that can provide some guide to us in which direction we are heading. So immediately 2 large bore cannula was taken, and the intravenous normal saline was started. Monitors were attached with ECG suggestive of bradyarrhythmias. So BiPAP was started with oxygen support. Patient was unconscious. So he informed me that patient is not responding to deep, but I will start with no continue BiPAP. I will reach in 5 to 10 minutes. Then we do what we can do. So we have started noradrenaline infusion simultaneously with EJV, and meanwhile ABG was came which suggests your pH of 6.96, PCO2 of 10, PO2 of 153 with about 40%, and BiCAP was only 2.3.
Excuse me,
yes.
What was the clinical diagnosis? Whether serious examination was done properly, whether neck rigidity or, as you say, bilateral pupil dilated, but the reacting to light.
So
Plantar were extensor. What you were suspecting on clinical ground before starting the investigation?
Clinically, I am dealing with unconscious patient,
Yeah.
which having a bradyarrhythmia, which having a compromised heart rate, which having a compromised breathing, and which having a compromised circulation. So in all the primary physician and primary survey, I will try to resuscitate the patient. So once I will try to resuscitate the patient with ischemic jugular vein, noradrenaline, initiate the ventilation, then I list down the causes, that what can be the cause, what I am dealing with the issue. So my first issue is I am dealing with the unidentified shock in this patient.
That was only 2.2.
Or 2.2. So 6.9 pH comes in our mind, then there are very few causes that lead to 6.9 pH.
The point is here patient started with gastroenteritis.
Yes, yes.
With hematemesis.
Yes.
That was the body.
Yes.
First thing which happened is the hypovolemic shock.
Hypo. Yes.
First thing which happened
So
was the hypovolemic shock. Maybe excessive blood loss. We have not measured. We have not measured blood loss.
yes, yes.
So we don't know what amount of
Blood is
hypovolemic shock was activated by the blood loss.
So we
The
are
second episode occurred something due to fluid loss, something metabolic happened, which led to bradyarrhythmia.
Yes.
Something happened which led metabolically, which led to bradyarrhythmia, and a bradyarrhythmia caused further cardiogenic shock, and patient became unconscious.
Yes.
This is what I gathered information from the history.
Yes. This is
Then comes your investigation.
This is perfectly right.
Upper GI problem with blood loss. That is what
This is
it
perfectly
is.
right. So we are dealing with unidentified shock. That can be hypovolemic shock due to blood loss or a severe acute gastroenteritis. That can be septic shock. We are not identified patient and severe abdominal pain. He might have a gastrointestinal or duodenal or jejunal perforation. He might have a medullary here or another something or a very large bleeding. He might have a cardiac cause in the form of acute
Young patient to get bradyarrhythmia is very unusual. Most of the time that bradyarrhythmia due to some metabolic components. Here I don't suspect any cardiac ailment.
That is also one message that this can have a cardiac ailment.
Unless he is in some underlying cardiac problem. Otherwise, from the history, it doesn't think a patient has a primary cardiac ailment.
So
When he referred to means it is cardiac event by general practitioners
Yes.
at periphery
Yes.
because understanding to
policy
policy
that your requirement PPM or TPM or coronary angiography or something.
usual scenario.
Usual scenario. That is why the case is that. So we are dealing with one hypovolemic shock, can be a septic shock, can be obstructive shock, pulmonary embolism.
Pulmonary within a few hours.
Not happen. If we go by the ABG, it also says that PO2 is 150.
Suggestive of acidosis.
Severe acidosis.
Severe acidosis.
Severe acidosis, lactate is more than 15. It is suggestive of severe perfusion. So 6.9 pH we normally found causes of 6.9 pH is usually identifiable causes like day-to-day encounter videos is a diabetic ketoacidosis. This is very common that diabetic ketoacidosis comes with 6.9 pH. PCO2 is 10. My one motive was to not intubate this patient by a junior doctor was also this PCO2 of 10. If one of my junior doctor or on-duty doctor will intubate the patient and he will keep the ventilator setting at respiratory of 50. Patient is in acidosis 6.9 pH, he will keep the respiratory rate of 50. If PCO2 is rise more than, he will require 10 PCO2. But we will not able to deliver PCO2 of 10 via mechanical ventilator. So I have insisted him that please wait, please keep on NIV, we will reach to the scenario and then we will decide that how when to intubate, how to do it. We will get a frequent call that sir, આપણે બધું બરાબર હતું જેવો સ્કોપ નાખ્યો પેશન્ટ અરેસ્ટ થઈ ગયો. બહુ બધી જગ્યાએ એવો call આવે. That is this reason when you intubate the patient, we keep the respiratory of 15. 15 is not enough to compensate the 6.9 pH. pH will further go down and patient suddenly got arrested. RBI RPS was 84 milligram per deciliter. Urine ketone was negative via dipstick. It was very small. Urine was present via catheter. Lactate was more than 15. NIMDF was 36.7. Serum acetone was 10. Sodium 142, potassium 3.2, chloride was 103. This was bradyarrhythmia. As an intensivist, तो वो आवा एकदम specific diagnosis तो ECG ना नहीं आवड़ता था.
आता थर्ड डिग्री ब्लॉक देव हेवी डिसोसिएशन देखा है.
Dissection ने multiple VPCs ने आवे છે એટલે અમારા માટે તો resuscitation ને adrenaline ને atropine ને. So we go by the ACLS formula. ACLS formula, patient is unresponsive and have bradyarrhythmia. You give a 3 dose of atropine, 1 milligram, 1 milligram, 1 milligram. Okay? અને બીજું અમને એવું શીખવામાં આવ્યું હતું કે ડાયરિયામાં એસિડોસિસ થાય અને if patient of acute gastroenteritis dies due to hypovolemic shock, then it is your mistake. So we have acted fast then. If patient is having acute gastroenteritis, so we have started resuscitation. And we have usually seen that if many of the menacing acute gastroenteritis patient, you give a 200 bolus, you give a 500 normal saline, you give atropine or adrenaline, there is some response. Everyone has seen that there is some response. If heart rate is settled down, if blood pressure is sometimes increases to 20 to 30 or something, patient usually in a hypovolemic shock, even if it is a bleeding, it is fluid responsive. So we also went into a direction of resuscitation phase. So then I came to the picture and then we intubated the patient and kept on mechanical ventilation. Then soda bicarb 100 ml 1 hour. Our registrar is also fond of soda bicarb. They don't ask anyone. This is 100 ml soda bicarb and start infusion. Bicarb and APG and soda bicarb. These three are very common. हमें पहुंचे नहीं पहला थी गई. પછી we have given atropine 1 milligram bolus for 3 doses every 3 minutes hour. But surprisingly, even after trying 15 to 20 to 30 minutes, we have sent all reports. All reports are on the way. We have also asked for echocardiography. Echocardiography machine is on the ground floor, so it is also coming on a first floor. So meanwhile, we are resuscitating this patient. 15 to 20 minutes passed, but not a single heart rate was fluctuating. It was coming to around 20 to 40, then it comes to 60, then again it comes to 20, 30. Then blood pressure is also in the range of 60, 50, 60, 50, 60. It is not also any picking up. And that in a general first initiation that I have precisely kept that neck vein was distended. That neck vein also we are not seeing regularly, but it was seen by regularly because we have tried to put a EJV in that patient, so it was very distended. So then we suspect that this might have some cardiac event or something. And so we have asked for an echo. Person was one of the registrar was an ENT resident, so he usually do the echo. Then when this type of patient doesn't respond, then we doubt ourselves. Then we are doing everything. We are doing noradrenaline, we are doing adrenaline, we are doing atropine, we are doing fluid. Still, no any hemodynamic response is coming. So we again go for the history. Then we hand over the patient to the registrar and we ask for the history. Then vomiting was sudden in onset, black in color, foul smelling, no hematemesis, multiple episode of watery stool, no malaria. History of diffuse generalized severe pains in last 2 hours. History of traveling since 2 days. Outside of food consumption was there. No history of fever, no history of any similar episode or no comorbidities or no any having a major illness leading to hospital before admission. The patient can present in aortic dissection like this sometimes. So patient can have a brain event in a subarachnoid hemorrhage or a large intraparenchymal hemorrhage. This can also be a bradyarrhythmia. But patient was not in a I cannot shift a 6.9 pH patient to the CT scan. So these are the related blood investigation that came to us. Hemoglobin was 12.6. So hypovolemic or hemorrhagic shock, we will doubt. Creatinine was 1.59. Urea was 39. Sodium, potassium, chloride, liver enzyme was also SGPT, SGOT is borderline elevated. Alkaline phosphatase is okay. bilirubin is okay. PT is mildly elevated, 1.39 or more than 3 seconds. APTT is normal, CRP is 1 milligram per liter, and vital marker HbA1c, HCV and HIV was negative. Ugly patient. કશું થતું નથી, ખબર નથી પડતી. હવે હું માથું કંટ્રોલ છું, મેં પુનિતભાઈ ફોન કર્યો. પુનિતભાઈ મેં નહીં પડતું. શું કરશું? તમે આવી જાવ તો એ બી આવી ગયા. સાચી વાત છે, એ બી આવ્યા. અમે બે જણા આ પેશન્ટ. અને પછી અમને એક છોકરા હેલ્પ કરી આપી. જે અમારો ડીએપી રેસિડેન્ટ હતો. ઇકો સિવિયર એલવી સિસ્ટોલિક ડિસફંક્શન, સિવિયર એલવી ગ્લોબલ હાઇપોકાઇનેસિયા, EF 15%, diastolic dysfunction, dilated IVC, non-collapsible, and then patient having the cardiogenic shock, severe acidosis, lactic acidosis, this is radiaria. Somehow, anyhow, when I have one thought in a strike that this can be a positive case. So we again sat with the relative and we asked her why. So what was the scenario? Then she told me, okay, we had a fighting at home. He was not at home. Since 2 days he was staying in a hotel. That's why I had a history of traveling and outside food consumption. Then he had a history of 2 days absconding from the hospital, from the home. Then again in a night. In the evening he came to home, and after evening coming to home, then we didn't talk to anything. Then we thought that everything is okay. This is happening to us in 2 to 3 months, and suddenly in a night he started this type of vomiting in me. Then we thought this can be a poisoning. This is what we have done a rise tube insertion, rise tube RT aspirate. It was came a black color of rise tube aspirate. Then one of the friend went to his car, and from car he brought a pouch of aluminum phosphate, and we are relieved.
Actually, the issue is that initially diagnosis also.
We are relieved that why patient is not responding to our treatment. If any of the cause that we are suspecting, he or she might have some form of response, but he was not responding to any of the treatment, and he came with a pouch of aluminum phosphide. We did a MLC, we managed then 2 to 3 hours, and everything was given, lavage was given, magnesium sulfate was given, sodium bicarbonate was given, vasopressor. Even we give an option of temporary pacemaker and ILP and ignore this patient, and patient expired within 2 hours.
The thing is that the relatives are from one side. Wife and his relative, and patient is from Punjab.
Patient was from Punjab. His marriage was happening in Gujarat, and they were not providing us any history.
They
Why
just give
this is
medical
happening.
history.
They are only giving medical history.
Then we asked him the patient is very serious.
Please
We need
tell
to
us
understand what is happening.
what is happening.
And then the wife has tell everything. પહેલા તો એવું જ કહેતા હતા ને કશું નહોતું સર ખાલી ડાયરિયા થયા.
And if this patient came to us and we have given a cause of death of acute gastroenteritis, severe hypovolemic shock, then it will create a lot of troubles to us in a further scenario.
When it comes to young patient,
Yes.
recently just 2 months back, one of the patient had very obstructive jaundice. Then the patient was alcoholic also. The patient came to me that I said that most probably alcoholic hepatitis.
Yes.
I know GGT પણ સારું રહે. But because GI physician said any ERCP કરવી પડે. In spite of my refusal, alcoholic hepatitis take long time to recover. He was not, within a span of 15 days, 2 weeks, he did not recover. And another ERCP कराई ना. The patient went for the ERCP by GI physician. Short GA was given, after short GA, patient went into cardiac arrest. Now thing is that he was just 35 years old. The thing was that that patient had alcoholic cardiomyopathy, underlying, and ejection fraction was only 15%. And he was admitted once for alcoholic cardiomyopathy at Bhajalpur hospital. That history was missing. My point is that in the nowadays young patient also try to look for underlying any major event or major what happened once in a while you come across in a young patient nowadays कि आप बड़ा लोचा हो सकते हैं.
So aluminum phosphide is a very known. It is easily available. It is used as government accounting OYO. It is very easily available and a very little dose is lethal. If you go for a Flipkart, you will easily find on 220 rupees solid alcohol. It is easily available. And in North and Saurashtra, people use and South region sugar and Valsad people very easily consume. So when the aluminum phosphide is coming in contact with the water or hydrochloric acid in the stomach, it releases the phosgene gas, and this phosgene gas is a fishy or a garlic powder. Exact mechanism of action of aluminum phosphide is still known, but there are multiple hypotheses of this aluminum.
ना ये बड़ी पाचन होती
It is difficult. So phosgene gas is rapidly absorbed, and if rapidly action, it action is very. If patient of your alcohol survives, then it is told that if he or she might have not taken alcohol, or it is a powder form or something denatured form, then only he survives. Otherwise, he cannot survive. So at cellular level, phosgene causes cellular hypoxia with non-competitive mitochondrial inhibition of cytochromes, so C-reactivase, which is very much required for the oxidation phosphorilysis. There is an increase in the anaerobic oxygenation. Also reduces the glutathione, which is the main antioxidant effect. Changes in the glucose metabolism, is increased anaerobic metabolism. Then there is a direct cardiac myocyte injury via phosgene gas. Why only cardiac is more important? But this direct cardiac myocyte injury via phosgene gas. There is direct vascular smooth muscle injury via phosgene gas. It causes increased vascular permeability. Whatever you transfuse via intravenous fluid, it always doesn't remain inside the vessel. It goes outside. So it is a very distributive shock. So this is ingestion of alkaline phosphatase, release of phosphine gas, cytochrome C inhibition, cellular respiration, lipid peroxidation, glutathione reduction, formation of superoxide catalase. Organ toxicity is 0.5 gram. This is the same like we have expired.
injection 0.5.
Only 0.5 gram. And one tablet contains 3 gram. One tablet contains 3 gram.
3 grams. The one tablet is
One tablet.
One tablet. And surprisingly, all these early signs or early symptoms are related to gastroenteritis. Early nausea, vomiting, retrosternal chest pain, multiple episodes of diarrhea, vomiting, anxiety, agitation, and garlic breath. Early sign of toxicity is patient has taken a tablet before 2 hours and the shock develops, or a tachycardia starting to develop, or arrhythmia starting to develop within 1 or 2 hours. So in a lesser time there is a development of shock or arrhythmia, the poor the prognosis. Cardinal feature is, usually patient comes with a shock in a shock state, but patient is conscious till the end, most of the time.
The gastroenteritis patient do not become unconscious.
Yes.
Even the patient हमारी age unusual है तो that patient became unconscious.
ये हमने भी नहीं समझा, तो आप तो हिस्ट्री में आते हो तो you are also gonna fix.
Hypoxia probably breaking.
Hypoxia was also not. Initially, it was started to do developing the hypoxia and patient reached to us. In a transfer phase or something. So ECG can show each and every type of rhythm you mentioned, from ST sinus tachycardia to depression to atrial fibrillation to any type of bundle branch block, elevation of these serum enzymes, global hypokinesia of left ventricular, intraventricular septum, 3D एकदम cold periphery, patient is very sweating and oliguria, histopathological examination, postmortem state, there is a focal necrosis of all cardiac myocytes, focal cortical suppression. That also is a contributing factor for a refractory shock. This is retro efficacy, but once the patient survives to 1 to 2 days after 24 hours, then there is a different scenario. Patient will have a leaky capillaries will lead to ARDS. Patient will have a shock liver will lead to jaundice. Patient will have a acute kidney injury which will take time. Sometimes it will take to ATM. Hypokalemia, metabolic acidosis, mixed metabolic acidosis, respiratory acute renal failure. Hypomagnesemia, hypermagnesemia is also usually found in older patients. And this respiratory shock will result into cerebral anoxia, usually present as a drowsiness, delirium and coma. So diagnosis is always based on a clinical suspicion and a history of ingestion by patient or relative. There is one test we call a silver nitrite test, that we put a silver nitrite paper in a gastric juice and we heat this gastric juice and it will cause a blackening of this silver nitrite paper. It will be done in a forensic laboratory. We will not going to do, but we as a physician or as a treating doctor, it is our responsibility by legal that we have to collect this gastric lavage. They will ask to only us. Gas chromatography is most specific and sensitive, that will detect the phosgene gas in the blood and air. Even small amount of phosgene will be detected. So, clue, what are the clues? Vomiters with rotten fish water or garlic water, cardiotoxicity in the form of rapidly developing refractory shock, arrhythmia and global LV dysfunction, severe metabolic and lactic acidosis not responding to any method, and apparently clear state of mind in spite of shock. These are some clues to suspicious cardiotoxic poison. Classic triad of hypotension, severe metabolic acidosis, and cardiac arrhythmia should raise a suspicion. Management is no specific antidote is available, treatment is mostly supportive. Mortality varies from 38 to 7% in a different case series. It is important to diagnose as early as possible. Keep general measure, keep patient in a well ventilated area. We should wear a PPE. All the contaminations we should remove. Resuscitation is most important. Airway breathing circulation is basic and important. Initial fluid resuscitation should be done cautiously via invasive hemodynamic. Vasopressin, noradrenaline, adrenaline, vasopressin. We should start. If patient develop
clothes material. Clothes material. Pediatrics tablets.
No, patient material for our safety. Patient has a vomitus, and this phosgene gas can contaminate us also for our safety. And this patient have a cardiotoxicity. So usually ketamine 1 to 2 milligram per kg is preferred during intubation. It causes less hypotension. Gastric lavage. So phosgene gas is immediately released after the injection. So if patient comes to you within 1 hour, so what you can do is there are some, they have tried many different methods. So one pathophysiology is that the tablet is mixed with the hydrochloric acid in stomach and it releases the phosgene gas. So they have tried soda bicarbonate solution with coconut oil, and they given a lavage with this. So it is no specific any difference in mortality. So it is not recommended, but they have tried. So what we think in aluminum phosphide poisoning, nothing works. So you can try whatever on the basis of your pathophysiology. Ultimately nothing works. So if you try potassium permanganate, it is bind with the phosgene gas and it to form the phosphates. It can also help an activated charcoal. After giving lavage, then you can do activated charcoal administration in a single dose or multiple dose. Acidosis is mainly due to cellular arrest and organ hypoperfusion. How many bicarb you will do, it will not going to support. But still dose is 1 to 1.5 ml per kg in a bolus dose and 1.5 to 1 ml per kg per hour to keep the pH more than 7. Magnesium replacement is the only thing that have shown some benefit in multiple test reports. Magnesium acts as a membrane stabilizer. So whenever your patient is having developing a tachycardia, you start to give a high doses of magnesium. So it can prolong the progression of this wide complex tachycardia or supracardiac due to hypomagnesium. Dose and duration of magnesium is controversial. There are multiple studies that have used different type of dose, but if you go by to all the regimen, it comes between total dose of magnesium of 9 gram to 12 gram in a 24 hours. So if you give a 0.4 gram per hour, then it also comes to 12 gram per 24 hours. If you given a bolus 4 gram, then 3 gram every 4 hours, it also comes to 9 to 12 gram. So you can use any of the region and it comes between 9 gram to 12 gram of magnesium. So that much of high amount of magnesium is required in experimental studies. So magnesium comes with its own cost, and you have to monitor sensorium, respiratory for patellar reflex or any to look for magnesium toxicity. Antioxidant also they have tried in many trial and treatment, but no one was effective in any of the. But you can try N-acetylcysteine is very cheap. You can use vitamin C is very cheap. There is a severely vasodilatory shock. You can give a methylene blue as a rescue method, 1 milligram per kg. Organ support, early diagnosis, acute lung injury will require intubation. The cyanosis not responding to oxygen can be due to methylhemoglobin. You can give a 1 milligram per kg of methylene blue. Soda bicarbonate, hemodialysis. Hemodialysis is not effective for the removal of the toxin, but it will clear the phosgene or it will clear the acid urine. Phosgene is usually excited in urine and also exhaled via expiration. So, જે પેશન્ટનું યુરિન ચાલુ રહેશે એ પેશન્ટ કોઈ બી મોર્ટાલિટી પર શું ટ્રીટમેન્ટ એ વહેલું ઇમ્પ્રૂવ થશે. So, maintaining adequate renal perfusion is mandatory. Use of IIBP is documented in severe case, but what happens in IIBP that IIBP have some trigger solution. It will require some trigger in form of a rate or a ECG or something, and this patient will have directly have cardiac stage, and IIBP people will not work in a cardiac stage. They have tried temporary pacemaker also, but there is a difficulty in electrical capture of impulse from the temporary pacemaker also. So the only modality that promotes nowadays is veno-arterial ECMO. Veno-arterial ECMO we directly bypass the heart and lung via peripheral veins. We use a femoral artery and femoral vein for the veno-arterial ECMO. So this is a case series published in Elsevier in 2016 from the Dayanand Medical College in Ludhiana, Punjab. They have included 45 patients and they have given a 15 patient ECMO. But they have not given each and every patient, because when to start a ECMO is also a question. You cannot start a ECMO in each and every patient. So they try to find a cause, they try to find some limit when we offer ECMO in a patient. So they have if patient ejection fraction is going below 35%, severe metabolic acidosis with refractory shock with systolic blood pressure less than 80, they have classified them into high risk group and offered ECMO. So in a patient, 15 patient was given ECMO and it have a 33% of mortality. So it have a lower mortality compared to the conventional treatment in a Dayanand Medical College. And nowadays many centers in Surat and many centers in South are in a range of 90% survival rate in alcohol poisoning. So this is also a indication and time of initiation. So all the patients who have given ECMO didn't survive. So in this table we see that survivor and non-survivor. So survivor delay in presentation 7 hours, non-survivors 12 hours. Then poison exposure to ECMO 10 hours, non-survivors 15 hours. And duration of, so if patient present to us in a delay more than 12 hours in a with above LV of 35% and pH, then it is less likely that this patient have the survival chance. Same, we should poison exposure to ECMO is also 15 hours. So we try to reduce the time to initiation of ECMO to give a good positive result. You see femoral vein and arterial, femoral artery and femoral vein. So when we put a cannula in a femoral artery, then we have to put a return cannula inside the lower limb to prevent the lower limb ischemia. Initiation, so we manage the blood cardiac output by the RPM. Monitoring, we need to monitor mean arterial pressure and mean output. And so once we start the ECMO and take patient on a ECMO machine, we try to taper noradrenaline and adrenaline all the vasopressure as soon as possible. 70-80 mean arterial blood pressure is okay. pH, platelets, APDT, daily echocardiography, complete coagulation profile. So when do we wean this type of patient? So we do usually do daily echocardiography. The MEH is more than 35%. Maintaining systolic blood pressure more than 90 without any inotrope support. Maintaining mean arterial pressure 70 mm of mercury. There is a recovered acidosis with good tissue perfusion. Gradually decrease the flow to 10 ml per kg per hour and continue till the minimum flow is achieved. Then we keep in a lowest flow possible for 2 hours. And after 2 hours, we shift the patient to the operation theatre and remove the cannula. So after cannulation, keep the patient bed for 6 hours and do not allow bed for minimum 6 hours. Monitor every side for 2 hours. Distal pulses, keep bleeding, keep side visible for 6 hours. No groaning for 12 hours. Complication. So there is a machine-related complication and patient-related complication. So this patient-related complication is very important. We have a very detailed consent form before it is starting for ECMO in each and every hospital. So blood hemorrhage, coagulopathy, thrombocytopenia, intracranial bleed, stroke, hypoxic ischemic injury, subretinal hemorrhage, critical limb ischemia, cardiac, myocardial shunt, renal acute kidney injury, ATM, constipation, GI bleed, sepsis. So I have seen each and every complication that is mentioned here in the ECMO patient. So keeping the ECMO is and telling that we will keep a ECMO and remove after 3 days is a very easy thing, but still we need to inform each and everything. I have seen all the things, all of these complications in the ECMO patient. So take home message is diagnose as early as possible gastric lavage, early initial aggressive resuscitation, magnesium supplementation, and timely refer to the center capable of ECMO. So, but more important take home message is this. After 1 or 2 months, this news came into the newspaper. The patient has sent a mail to his father that I am going to suicide and I am doing a suicide, and it was a timer emails. So when he committed a suicide and all the timer emails were sent to his father. His father came from all the way from the Punjab, and that he accuses his in-laws about murder and all things. And if we have given a case cause of death of diarrhea, vomiting and alcoholic shock, there will be one more line that doctor was involved in giving a false certificate, that certificate. So we saved our life from this situation. The doctor was involved in giving a false certificate. Even my son is claiming that he has committed a suicide. So, भगवान की कृपा से ही दिवसे हमारा